Welcome to GenQA's Tissue-i webinar. Today we're going to be focusing on the lung cancer tumour assessment for molecular testing, and we are joined by two of our expert panel who help advise and guide us to deliver the Tissue-i EQAs, and that's Dr. Anka Onescu from NHS Lothian in Edinburgh and Brendan O'Sullivan from UHB in Birmingham. I'm Sandy Deans and I'm Director of GenQA, and we're also joined today by Abby Trosh, who is the GenQA Tissue-i lead and manages the EQA assessments. I'm just going to start off by giving a very brief introduction about what Tissue-i is and some of the results that we have seen in previous EQA runs. Then I'm going to hand over to our two experts, as I say, from the GenQA Tissue-i expert panel, who are going to go through 6 cases from previous EQA runs in depth and give us some thoughts on their expertise of how we should be assessing tumour content and cellularity for these cases. Then it's your chance to ask your questions, and we're going to be running a live question and answer session. So please do submit your questions that you would like answered by the panel or around GenQA delivery of Tissue-i into the system, and hopefully we'll be able to address them after the presentations. So just to start, to put it in context, what is Tissue-i? Well, this is about assessing how you look at tissues, histopathology tissue assessment for genomic testing. Now, this can be for whole genome sequencing, for particular clinical indications, or it can be for large NGS gene panels, or also for single gene tests. It really is about performing that assessment to make sure that you are actually testing tumour tissue for genomic variants. It's a web-based module, which means that anyone can participate wherever you're based globally. And we cover now 9 different tumour types. And the reason for this is we're aware that different individuals specialise in assessing different tumour types. So we really want to provide as much assessment as possible for as many individuals. Now, this is different from a lot of external quality assessment schemes and also proficiency testing that is provided because it's not laboratory based. It is about individual participation. And because of this, the no performance assessment is applied. So it's more about benchmarking. So it's an educational exercise. So individuals can actually compare themselves with colleagues to see whether or not they're coming up with sort of the same tumour assessment and cellularity percentages when looking at the same slides. NHS England funds any individual who is linked to an NHS genomic laboratory hub, but also this participation is open to any interested individual. So the system, as I've mentioned, is online. We use the PathXL visualization tool, which allows you to move around the slide as you would with a normal microscope, and also zoom in, magnify to the areas that you would like to inspect more closely. This was originally used because we also used the PathXL Tissue Mark program, which gave us an estimation through AI of the actual tumour content. This has now been taken over by Philips and they're now owned by Ceradan, but we work very closely with the system. I think the feedback we get from participants is very positive, and we like the ability to be able to mark up areas for macro dissection. And this is something that we like to feedback to our participants on the consensus of the markup. How do we know what the right answer should be? This is a question that we're always asked, and it's very, very difficult because it is subjective. So both for tumour content and cellularity, we've taken 2 approaches. One is looking at the consensus estimation submitted by all participants. So you would hope that everyone, as they're looking at exactly the same tissue image, that they would be coming up with a close consensus of what the true results should be. And also we have stood up an expert panel. So we have a range of individuals who routinely assess the tumour content of diagnostic pathology samples for molecular testing. So we use the term expert loosely because, again, how do you define an expert? But we consider individuals who are routinely assessing day-to-day, many samples going through for molecular testing and successfully obtaining a genomic test result, that hopefully that they will come up with a consensus between themselves as well. So in the bottom left here, you can see an individual report. This goes back to all participants. It's the data that has been submitted by that individual, and also the markups of any tumour content on the slide deck. And then on the right-hand side, we also issue a EQA summary report, which brings together all of the data that has been submitted by the participants, anonymously, of course, and also the feedback from the expert panel. And really using this, you can look at your own data that you have submitted and can benchmark yourself against peers. Lung cancer has been one of the very first tissue modules that we launched, and we did see right at the very beginning huge variation in the estimated tumour content submitted by participants. And here is a snapshot of 5 of the current EQA cases that were delivered in 2021 of the estimated tumour content submitted. And I think here we can see that there is still huge amount of variant amount of estimated tumour content submitted, particularly, for example, the top left graph here, you can see that we have submissions of 1 to 10% for tumour content, right through to over 80% tumour content. And this is, just to reiterate, individuals looking at exactly the same tumour section on the Tissue-i system. So I think increased participation and more education is definitely needed in this area, just to bring about some standardization. As I mentioned, we also look at microdissection areas marked up. This is something that has never been done before, and really it was quite important to see how individuals approach this. The 3 images along the top of this slide are submissions from 3 separate individuals. On the top left here, we have a very wide circular area marked up for microdissection for DNA extraction, which also encompasses in the centre some necrotic materials, so probably not ideal for DNA extraction. In the middle at the top here, we have a very defined space marked up of tumour for extraction. However, on the right-hand side, we have a very detailed markup which encompasses more of tumour areas and omits the necrotic material. So really this is what we're looking for. Along the bottom, we have 3 images, and this is submissions from 1 individual. So in the first instance, you would say there's 3 very discrete areas for markup, and how difficult could this be for those individuals in the laboratory trying to scrape off that material, in particular on the bottom left. However, we don't know the best practice that's performed in that laboratory. They may be using cores to do this. So in a way that this would be exactly what the laboratory staff were looking for. So again, this is an example of why we do not apply performance criteria, because from this assessment, we are not aware of what local practice is and what local good practice is. It really is about just sharing the information that colleagues are doing and their approach. I think what we can say is we're now getting really good consensus of the areas that are being marked up for macrodissection. These are examples of 3 of the lung cancer cases in the recent EQA module, which was run this year. And you can see here that the areas marked up are layered upon each other, and you can see quite a high consensus there of the regions that should be marked up. So I think that has definitely been an improvement that we've seen across the years with continued participation. So we started off in 2015, and as I mentioned, we focused on lung and colorectal because that was really the mainstream tumour type that was being assessed for genomic testing. We have then gone on and expanded to incorporate more different tissue types, and really again, as I mentioned previously, this is to expand and extend out the participation to individuals who are maybe performing more specialist assessments on different tumour types. We've also evolved the colorectal cancer scheme into gastrointestinal EQA, and really that is to be able to rotate between upper and lower GI between lungs. The ovarian scheme has also been morphed into gynecological tract cancers, prostate into urology based. And again, this is to be able to expand the number and the types of cases that we can provide for Tissue-i. We've also got breast, melanoma, sarcoma, CNS, and we've also introduced pediatric, predominantly neuro, because these are more specialist tests, types of assessment, then we rotate them. So we're not swamping everybody with multiple cancers to assess on each EQA run. So I think we can say in particular for lung, there is still variability and lack of concordance for both the percentage of tumour cells, and I haven't shown you any cellularity data, but that is still the same as well. It's still got variability. Variability in areas to be macro dissected, but I think in particular for lung, maybe not so much of the other cancer types, we are seeing improvement, and that is really great news. And I think the take-home message is need for standardisation and through education and training, EQA feedback and continual participation. And hopefully the review of the cases today, which is about to follow, will also help educate and train individuals who are looking at assessing tissue content. So now I'm going to hand over to our expert panel, to Brendan and Anka, to review the lung cancer cases. Lovely. So Anka, do you want to start the review of case one, please?
Thank you, Sandy. Yes, so we have a core biopsy here, and as the clinical history tells us, this is from a female smoker patient. So we can see that low power, it's quite difficult to appreciate if the busy areas, the blue areas on the slide are tumor or not. So one would have to go high power and start screening the core from one end to the other. A significant amount of inflammation is on the slide, and if we start moving across the core, we'll get hopefully to some of the tumor areas. So that's where we see most of the inflammation at the moment, lymphocytes and macrophages and a few of the plasma cells probably. And within quite a fibrotic background. But moving on, we hopefully will get to some tumor areas. We can start little blurred glands coming into the field just now, into the view. And this is where the tumor is present. So significant amount of inflammation. Now some of the ill-defined glands, quite subtle tumor present there within significant inflammatory background. So is not to say that a significant number of the lung samples actually do look like this one. So not a lot of tumor present with inflammation, with antacotic background. Sometimes there can be core biopsies taken from lymph nodes. And so we do have this challenge where the amount of tumor and the ratio of tumor between tumor and inflammation is actually very, very low. As you can see, this tumor has been estimated by the expert group to contain between 1 and 20% tumor. So I think I would be probably even significantly lower than 20. This is just the group within this is present. Now we get to an area that's just in the field of light now. That's a much better area in terms of tumor proportion compared to the overall total cellularity on the slide. But this is a very, very small area on the core. So one would have the challenge of considering macro dissection in this case. If the core is good size enough, then one could consider macro dissection, but it may be the case that if that area that's for macro dissection is very, very small, you may not get sufficient DNA and RNA on this slide from this particular case. So the overall cellularity is been regarded as medium. It's between 4,000 and 10,000 cells in total. And in that particular core, we can see that one of the slightly paler end, that's the one that's more tumor rich, you may consider macro dissecting, but we can also try to use the whole slide and again, considering the cellularity, the tumor content that we have just mentioned, between 1 and 20%. Probably more closer to 10, I would say.
Thank you, Anka. Brendan, do you want to add anything?
No, I mean, I would be agreeing with Anchor entirely. These are the sort of cases that really make the case, if you like, for macrodissection, because you see such a big um, difference in the tumor cellularity depending on whether you can macrodissect or not. These lymph node mets are very challenging, and this is actually not such a bad case. We do see those ones where the tumor is much more dispersed in the background of the lymphocytes, and they're entirely unsuitable for macrodissection, which makes them extremely challenging. But no, I think that it really, again, it's a good example of where you need to tailor how you approach a case depending on what you're applying it for and what your downstream applications are.
Thank you. So we move on to case 2 now. Anka, back to you.
Thank you. Yes, so now we have a resection, and we can see that there is a relatively normal lung parenchyma in the background, right in the middle of the slide. But we do have some areas that are slightly more cellular, especially towards the left side of the section, where we can see there is a little bit of inflammation, but we'd have to go concentrate on that area to see if this is where the tumor is present. So if we go slightly higher magnification on that side, higher power on this side, we do have a papillary glandular tumor that actually is present, surrounded by a significant number of lymphocytes. So there is a bit of hyalinization. There are some areas of the tumor that are probably more fibrotic in type, some areas of the stroma that appear more fibrotic. The clusters of lymphocytes and the perivascular inflammation seems to be present throughout the whole area of the tumor. So I really don't think that would be possible in a case like this to avoid that inflammation, because one would have to really end up with some very small areas for macrodissection that again are not possible to be done in the lab. So we'd have to consider the shape, the type of macrodissection that we request our technicians to follow in the lab, and how much tumor there is in the background, and the ratio between tumor and inflammation. So if we go back low power on this one, you can see there are two areas. It's actually a surface area. They are not bad at all. The tumor cellularity in those areas has been considered between 1 and 10%. And it's because there is significant tumor, but there is also significant amount of inflammation. So we would not go any higher than that. In terms of the cellularity in the areas that are marked, and the overall cellularity in the whole slide, this is high cellularity, considered as more than 10,000 cells. Thank you.
Brendan, anything else?
Yeah, absolutely. So, I mean, as someone who has spent several years in the lab scraping slides, that's a point I would reiterate. There can be a temptation when you have these mixed populations to try to pick out what you think are the richer areas to go for a higher tumor cellularity. But that can be misleading. It can almost be impossible for the technicians to do. And the danger is that you try to become too specific, and actually what you are picking out is not the tumor. You're going for very small areas that you can't really see using the naked eye. And so your risk is that actually you are under the misapprehension that you have a richer sample than you really do. So as Anka says, you need to be pragmatic in approaching these. And I think for those of us who are not pathologists, this is a good contrast for the case with the lymph node metastasis, because here you have to know your what you would expect to see in normal background lung or non-malignant lung tissue, and be able to know your different cell types. Where you have your metastases, typically your tumor cells are a stark contrast to the lymphocytes you can see in the background, whereas here you need to actually understand your background lung histology as well to be able to be absolutely confident of what you're selecting. And not so much in this case, but some tumors can look not so malignant in the cells, can actually not look quite as atypical as they do here. And so being familiar with what you should see in non-malignant lung is a very important thing for us to be able to do when we're approaching tumor selection for these sort of cases.
Great, thank you. Brendan, back to you.
So here we've got one of the common diagnostic samples we'd see. So we've got a core biopsy from patient with a lung lesion. There, as you can see from the case information, it's already been described as appearing to look like adenocarcinoma, and really that's what we're looking for when we first get our diagnostic samples. Are we looking for a malignancy? Are we looking for small or non-small cell? And if we're looking for non-small cell, can we further type that? And from a sort of diagnostic point of view, these samples are nice, if you like, that when they're fairly clearly differentiated, you don't require lots of additional work for the diagnosis. The key to us is deciding how much of this we should take from the core itself, and these sorts of samples can vary wildly in terms of how much tumour is actually present. If we're able to zoom in just a little bit, we can see that we as a group have selected the area where you can see the malignant glands here. Now, although the tumour is very much apparent, so you can see these atypical epithelial cells throughout the section here, the key thing to remember is not to be kind of misled by just how striking the tumour is, because you do have consistently through the core this background of cells which are going to dilute out that tumour content. And obviously, as we all know, the tumour cells are larger than a lot of the background cells, particularly the lymphocytes you have. And if you've got inflamed lung, that can really dilute down the tumour percentage. As a group, we decided that we would call the tumour content for this between 11 and 30%. You see a lot of these sort of core biopsies which are around this tumour content, and I would call it exactly that. They tend to be no better than sort of 20 to 30% at best. So it's important still, if you are thinking about enriching, to consider macrodissecting. Even if the non-malignant areas are not terribly cellular, they can still cause a severe dilution effect. So for comparison, again, they're not as densely populated as say the lymph node biopsies were by the lymphocytes that are present in the areas which are non-malignant, but it's still I would always encourage my staff to try and look at whether they can macrodissect these just to bring that tumour percentage up a little.
Thanks, Brendan. Anka, do you want to add anything to that?
That was perfect. The only thing I was going to add, and perhaps this is for the pre-analytical phase of this, we see that there are two different cores on this biopsy. And I think what we do in the labs, in the histology labs that work very closely with molecular labs, is try to embed these different bits of tissue in different cassettes just to facilitate the use of, to rationalize the use of tissue, if I can say that, because on some lung biopsies, this can be also coming from metastatic disease. They're not always primary lung disease. So the pathologist would have a duty to really try to make sure that we get the correct diagnosis. Obviously, you would need the clinical information to know a bit of background about the patient and the presentation of the patient. But taking these different cores of tissue in different cassettes would help actually do immunohistochemistry to be able to have an accurate diagnosis on one core, perhaps. Maybe do some immunohistochemistry, because we would do as a first screen ALK and ROS could be done by immunohistochemistry, and then consider a core for DNA or RNA if that's also required on the case, depending on the clinical presentation. But we know now that most lung tumors do require molecular testing. So I think we've moved from a request base into almost reflex for all the lung tumors to be tested for molecular, definitely adenocarcinomas and non-small cell carcinomas. So embedding the tissue in different cassettes can help with not running out of tissue if you need more. Thank you.
Great, thank you. Brendan, back to you.
Okay, smashing, thank you. So here we have another example of a resected tumour. So again, it's another adenocarcinoma. We're looking at quite a large lesion, so we're in a good place in terms of making sure we have enough material for analysis. I think the key thing for these is just to make sure that we are being selective enough. The temptation is to assume that resections are better samples because they have more material available, but they can still be quite challenging in terms of having sufficient tumour content. In terms of ease and macrodissection, you can see that the group has selected just a single area, which we've highlighted. But in terms of what can appear at a low power as the entire lesion, actually we do need to go on to high power to check what is tumor and what is not. These lesions can become very fibrotic and sometimes quite inflamed, and those are the issues we can have in terms of making sure we have adequate tumor. So within the area we've selected, you can see the glandular structures of the adenocarcinoma itself. Where the tumor is present, it's relatively rich, but you can see all the way throughout we've got this quite abundant lymphocytic infiltrate, and that's the thing that's going to cause us a problem in terms of our overall tumor percentage. I think although kind of as a community we're coming to understand the content of these sorts of samples, traditionally they were the ones that I think we all overscored because we felt that they were great samples. The marking group actually went for a tumor content of 11 to 20% for this. So if you think back possibly to the diagnostic biopsy we had to compare those, the diagnostic biopsy was in some ways actually better, mainly because it had less of this inflammatory infiltrate, and so if you like was watered down less by that content. So within the tumor area we've marked, it's quite homogeneous. There aren't many areas that are richer or poorer, hence why we've taken this entire area. But there are no real areas, conversely, where there's a much denser pattern to the tumor. And so actually you can't improve much beyond that kind of 20% mark in this sort of case. Again, the cellularity though is very high because this is a large lesion. It's not incredibly densely packed tissue, but you're covering such a large area that you can be fairly confident that you're going to harvest an awful lot of cells from this and get over that 50,000 cell mark.
Anke, anything you want to add to that? Thank you, Brendan.
That was perfect, Brendan. I think the only one thing I would add is that you said that we have taken a crescent shape of the actual tumor. I think if one pitfall may be the fact that somebody might just go quickly and circle the whole area, including the center of the slide actually, and that center of the slide does not contain a lot of tumor, if any tumor at all. I don't think there are many invasive glands in the middle of the slide, so that can be one of there is a little bit of tumor, but that's a low cellularity and a low proportion of tumor compared to the actual crescent shape that Brendan had discussed. So I wouldn't take the center of the slide, and that's exactly what the consensus group agreed in terms of macro dissecting the area that has a much better tumor proportion. Thank you.
Great, thank you. Okay, so Anke, do you want to talk us through this case 5 biopsy?
Yes. So the difference now in this case compared to the others is that we have a bronchoscopic biopsy, and so the shape of the fragment is slightly smaller. We can say that they're quite hemorrhagic. There is a bit of blood in all the fragments. So what one should do is perhaps go high power in each of these fragments to establish if they all contain tumor and what is the proportion of tumor compared to the background cellularity, inflammatory component, and so on. So we have islands of a poorly differentiated carcinoma there, but quite a cellular background with fibrotic tissue and inflammatory cells. So we see that the tumor seems to be scattered homogeneously throughout the core, throughout the fragment, and there is nothing that looks more concentrated in tumor compared to the rest of the slide. We've got a little bit of bronchial mucosa as well that looks normal, but one would not be able to macro dissect that one out. So this fragment also looks equally good, we can say. Tumor and inflammatory cell component, again, mixed and not possible to macro dissect one from the other. And so the expert group had agreed that the tumor proportion in this case is between 21 and 40%, and the overall cellularity in the slide is medium. I would not macro dissect a case like this one. It will be taken as a roll in a tube because all the fragments show a similar proportion of tumor compared to the background normal tissue.
Thank you, Anka. Brendan, anything else to add to that? That's great.
No, really nothing at all. Anka's covered everything on that. I mean, I think one of the questions I get asked occasionally by scientists who are a bit less familiar with what they will see morphologically is, do they need to worry about hemorrhage in the same way that we're concerned about necrosis? And the answer is no. We don't have any evidence that including hemorrhagic areas is a problem. Your DNA extraction method should eliminate that. So, and obviously there is no DNA content because that's derived from red cells, so you don't particularly need to have any concerns about that. Sort of putting on my hat as someone who's not a proper pathologist, I think the one thing that can trip people up occasionally on these sorts of biopsies is dysplastic areas and dysplastic epithelium, and people have a concern over whether they're confident that that is tumor or non-tumor, and do they include it in the tumor content assessment? And if you have any, concerns over that as a scientist who's perhaps not entirely confident over distinguishing dysplastic areas from actually malignant invasive areas, then that's when you seek the advice of a pathologist who can be totally confident in giving you that support.
Great, thank you both. And now we'll move on to our final case from the Tissue-i module. Anka, over to you, please.
Thank you, Sandy. Yes, totally different from the other cases that we have discussed. We can see now a significant amount of lung tissue. This is a case from a resection, and quite quickly the pathologist would go to the area that looks more blue in color, the cellularity, increased cellularity, and this is where we would hope to find tumor. And we actually do have this papillary tumor in the lung parenchyma that doesn't have, as we can see, much inflammation around. So the tumor proportion is pretty good in the area, but there are a few lymphocytes now coming in. What we actually find in these cases is that it's not necessarily the lymphocytic background that we have to see. It's also sometimes we can find significant number of histiocytes and alveolar macrophages that can also dilute down the tumor DNA. Now in the center of the tumor just now, we can start seeing a significant number of lymphocytes actually appearing. So the size of the lymphocytes being a lot smaller, and this is quite, the cells, look, the tumor cells are quite large in size as well. That can be quite misleading in terms of judging the proportion of tumor versus background normal. One of the considerations that perhaps one needs to consider is that when we cut the sections for macro dissection, the three-dimensional representation of the lymphocytes compared to tumor cells in those thick sections, because if we consider a medium size of a tumor cell as being a diameter of being 20 microns, a lymphocyte is perhaps 5 or 6. And so in the thickness that we cut, in the section that we cut, we will get definitely a significant higher number of lymphocytes represented and used for DNA extraction than there are tumor cells. So in that area that would need to be macro dissected, one would not consider taking the whole section for analysis. Then we'd have agreed that the tumor cellularity is between 11 and 20%. It is a good case to do molecular testing on. There is another tiny area we have not concentrated on. That's another tiny lesion that can be taken. And again, if the tumor proportion is good in this area, then one can consider taking 2 areas. One point to make, if this is really, really small and difficult to identify on the slide, because when the sections are cut, that may be quite difficult for one of the technicians to actually identify the area on the section, then the large tumor may be sufficient enough in terms of macro dissecting and using that from a couple of sections. And that's all I can think about on this case. Thank you.
Thank you, Anka. Brendan, over to you. Anything else?
No, not really. I mean, I think that, as Anka's summed up really nicely there, it's the kind of case that can slightly trick you into thinking that the lesion is not that influenced by the non-tumor content, and almost because the tissue in the background seems so it's not densely packed with non-tumor cells, that can you be pragmatic and just take the whole thing? But actually, you're already seeing significant dilution within the tumor areas. So if you then decide not to macrodissect those out, that really is going to bring your tumor content down to a significantly lower level. I think thinking almost slightly in a different direction and thinking about non-sequencing methods, even though the focus very much is on ensuring we have the right content for sequencing. If you are thinking about a morphological test like FISH, I think sometimes these are the kind of cases which occasionally some of the scientists find challenging, because within the lesion, how are they differentiating those tumor cells from things like the macrophages, larger cells that are present within the tumor alongside the tumor, and being absolutely confident that they're looking at the right cells once they get to something like a FISH prep. So again, to have some guidance from an expert pathologist, or again to even look at things like the immunohistochemistry if you have performed immunohistochemistry on this lesion, can be a useful guide for you. And just to be aware of that as a kind of a pitfall, just because an area is selected and highlighted doesn't mean that everything within that area is tumour. You know, actually the tumour is still the minority of cells within that area, even after it's been highlighted. So just to bear that in mind.
Great, thank you. Okay, thank you very much to both of you for some excellent comments and great educational piece there. Thank you so much indeed. So we have some questions coming through for us. And again, I would just like to ask attendees, if you do want to ask any questions, then please do add them to the questions box and we'll get to them. So I know, Brendan, you have a challenging question for Anka to kick us off. So I'm going to come back to you then, please.
Sure, it won't be challenging for Anka. So we've seen some good examples there across the different sort of types of tissue specimens that we get from a variety of sites, primaries and mets and so on. But I think those of us who work in this know that we quite often see a lot of samples that are actually not classical tissue biopsies. So we might see things like pleural fluids, classical cytology, or we might see things like EBUS samples. So I was just thinking, in those cases, what are the differences in the ways we assess those compared to, say, like a classical lung resection or a core biopsy?
Yes, challenging ones, especially since the number of lung samples can be quite significant. A significant number of them can be cytology samples or EBUS samples, and their number is higher just because the clinical journey of the patient to the clinic sometimes can take quite a bit of time. And so the clinician sometimes can take that cytology sample as a quick diagnostic sample without really giving consideration to the amount of tumor that cytology samples do have. And this is this can be a challenge, because having a diagnostic does not mean that necessarily one can perform the full molecular diagnosis on the sample. So they are not really suitable for macrodissection. It wouldn't, they would not be any good for that, because we cannot really predict what's in the deeper sections once we cut beyond the H&E. And one other challenge would also be knowing what tumor and what's macrophages, especially for the pleural samples that can have a very diffuse infiltrate. And by that, I mean single cell tumor population. And because mesothelial cells that are very reactive can look exactly the same as tumor cells, it can be a challenge even for the pathologist to identify those. I sometimes refer to the whole immunohistochemistry, and I sometimes discuss the case with other colleagues just to be able to say that I do have sufficient tumor to be able to take it through for molecular testing. Because if you get absolutely no mutations at all, it can be misleading thinking you've got a sufficient sample, but actually it can be a false negative result. Not many cases are like that, but we do see quite a few cases in routine practice. So that can be the challenge on those.
Thank you both. Angus, so just to follow on from that then, so what percentage of samples coming through are more cytology based then? Have you seen a change from biopsies coming through to cytology, or is it really just still quite static?
It depends where the patients are seen. So sometimes if they are seen in one of the peripheral hospitals, it may be that they could be referred to have a core biopsy, a CT-guided core biopsy in the center, or sometimes they can just have maybe a quick aspirate, or they can have a procedure that's done then and there if they have a bronchoscope, and if they have actually, that's a site that is equipped with EBAS technology. But in Nodian, when we audited our numbers a few years ago, 30% of our lung samples were cytology. And some of them are really good, absolutely no problem, but some of them actually can be extremely challenging. I suspect the challenge would be knowing if the patient is well enough to have another procedure. But if molecular diagnosis or if the clinical presentation of the tumor would suggest a driver mutation, then the oncology team and the radiology teams are quite often keen to push for that biopsy to happen. But we see a significant number of cytology samples through, and it all depends on comorbidities of the patient as well, if they're taken forward.
Brendan, are you seeing the same situation in your hospital?
Excuse me, sorry, while I unmute myself. Yeah, it varies wildly, but yes, we are, and I think we have, as a diagnostic community, worked very, very hard to make sure that we can get a diagnosis, a tissue diagnosis, if you like, or a cellular diagnosis for any patient, you know, so that we're not leaving people behind and only diagnosing them on, say, the radiology and that kind of thing. But that does mean that we have become more and more efficient in pathology at using smaller and smaller, worse and worse samples. So as Anka absolutely says, you have to put these results into the context of what you're dealing with, and be able to understand that different samples obviously have different parameters to them that are going to affect the testing you can do. You know, they present headaches to us in other ways. For example, not in lung, but in other tumor types, there are certain PD-L1 tests that you cannot perform using cytology samples. So there's an array of different issues which can be challenging, and it's about having those conversations with the clinicians as well, so that they understand that there are some limitations on what you can do with a pathological specimen.
Absolutely, thank you. And really another example of multidisciplinary team working, not just when it comes to the results, but actually the testing and what you can do with those samples coming through. Yeah, that's great. Can I ask you, from the data that we presented slightly earlier, there was still huge variation in the estimation of tumour content in lung cases in particular. Are you surprised? Anka, I'm going to ask you, are you surprised? Do you have an inkling why this is still the case? I mean, lung is one of the ones that we have been performing molecular testing on for quite a while now. It was one of the first with a target to come through for molecular testing. Do you think we should be better now? What do you think the issue is?
All the people who be better. I wonder if actually the fact that in this game maybe do live sample, discuss them with all people who participate, another colleague. So I sometimes use, and I know that's just not a very, it's an approximate way of looking, but I use the results that come back from the lab, especially sequencing, and I look at KRAS sometimes, and that variant allelic frequency gives me a little bit of feedback on the actual tumor percentage. I don't use the EGFR result as such because we know that can be associated with amplification, but the KRAS is much more easier to use. And so that's always feedback to me, because the scientists would come back and say, I'm only picking up a 10% KRAS and you said this tumor is 80%. And so I'm looking back at it sometimes and I would use that as feedback for my tumor percentage. But I think discussing the case with your colleagues, if you are not sure, an overestimation can be the cause, or maybe the inflammation is judged just on a two-dimensional section rather than actually thinking that when you cut 6 sections from a block, you get a lot more lymphocytes than you get tumor.
Yeah, I think that's a really important thing, isn't it? This is all very, as you say, two-dimensional, that in the real world, that is not what you're working with. Absolutely. Brendan, have you any thoughts?
I think lungs are one of the hardest samples to assess, you know, and of the sort of the big three of lung, colon, and melanoma that a lot of emphasis has been on because we've been able to challenge them with agents. Colons and melanomas are less challenging samples. Once you have that diagnosis, melanomas can be a nightmare to diagnose, but once you have the diagnosis, the tumor quantification itself is not quite so difficult. I think it's what is very interesting, although I could be extrapolating here, is that some of the data, so I'm thinking of the data that Alex Harrigan has around PD-L1 analysis, shows that there is a great deal of variation in how people perform their PD-L1 analysis in lung as well, which just, I think, reflects the fact that it's a challenging morphology. And if you are, you know, not that familiar with what you're seeing, there are big pitfalls in terms of being quite wide of the mark in terms of an assessment, and that goes for other semi-quantitative things such as quantifying the PD-L1 expression. So it's the most challenging to deal with, aside from possibly one or two rarer tumours, but of the very common tumours, I would say it's the most difficult to assess.
Great, thank you. So I think maybe not be too hard on ourselves then when we don't have huge consensus across the samples, but I guess my experience, more and more experience, and as Anka says, tying in that genomic test result data as well as we go forward, then education and experience. Okay, thank you both very much indeed. And Abby, can we just move on to the next slide? So it just leaves me to thank you very much to both Abby for running the webinar for us, and Anka and Brendan for giving your great words of wisdom and sharing your expertise with us. We would welcome some feedback from those who have joined us today, and a survey will be sent out shortly after the webinar finishes. And you'll also have participation certificates sent to you for your own CPD or CME. This webinar will be available to view on the GenQA YouTube channel from the 10th of January, and you'll also be able to view the other two webinars that brought together in this series, which is the prostate cancer and the lung cancer, and the gynecological tract cancer, particular ovarian, Tissue-i webinars that will also be available on the YouTube channel. So thank you very much indeed, and I hope you found this a very useful webinar.